Hi, I'm Don Berwick. I'm a pediatrician. I'm the former and founding president and chief executive officer of the Institute for Healthcare Improvement, IHI, in the United States. It's an organization that works around the world to try to help improve healthcare everywhere. And I'm recently the former administrator of the Centers for Medicare and Medicaid Services in the United States. That's the government agency that provides coverage for people in the Medicare, Medicaid, and children's health insurance programs. I'm delighted to be able to join you this way and to speak with you a bit about the possibilities for improvement of healthcare in all countries. I think it's fair to say that in all countries, healthcare is troubled. Good people work in it, doctors and nurses, pharmacists, therapists, managers every day trying to provide care to people. But often the healthcare system fails to meet the needs in the form that we really would wish to meet them. The reasons for this are complex. They do not lie in bad intentions or lack of skills or poor attitudes in the workforce in general. Doctors, nurses, and others want to do very, very well. But they're trapped in systems, historical systems of design, the work context, the way that processes go in healthcare that make it very hard for them to meet patient needs. Here in the United States, we have a tradition around identification of the gaps in healthcare, the needs for improvement, which were collected and published by our Institute of Medicine and our National Academy of Sciences back in the year 2001, an important American report called Crossing the Quality Chasm. In that report, the needs for improvement were designated as 6 in particular. Safety. Lots of people get harmed in healthcare by the care that intends to help them. Complications after surgery, medication errors, pressure ulcers, infections that could be avoided, mishaps in care. And so the first improvement area is safer care. The second is more effective care. This means promising patients and families that people who are ill will get the very best care that science knows to give them and will not be subjected to care that cannot help them. And for those of us who are well, it means promising us access and to the best possible scientifically supported preventive care, and not being subjected to care that can't help us. Safety, effectiveness. Patient-centeredness is the third dimension. Patient-centeredness is a really important idea. I think it's the key idea, and that is that we are guests in our patients' lives, and a healthcare system that performs well is meeting the needs of each individual on their terms with respect to their background, their preferences, their language, their value structures. We serve the patient, not the other way around. The fourth dimension is timeliness. That means engineering delays out of healthcare. Delays are often thought to be due to poor resources, insufficient resources, but actually often delays come from the design of the care itself. And with the same or fewer resources, we can engineer delays out of the healthcare system by using modern scientific approaches to system design, queuing theory, and so forth. The fifth dimension of the 5, safe, effective, patient-centered, timely care, is efficient care. That means reducing waste in the healthcare system. Ask a nurse or a doctor or a manager how much of their time is wasted in procedures and forms and other kinds of activity that don't add value. So efficiency is the fifth dimension. And the final one is equity. In the United States, that means closing gaps, racial gaps and ethnic gaps in health status between minority and majority populations, between the wealthy and the poor. Those are the 6 dimensions of improvement that our Institute of Medicine commented on: safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. Very important list of things that ought to be better about our healthcare system, and indeed those in most countries. The Institute for Healthcare Improvement, the organization that I worked in and helped lead for almost 20 years, took that list and broadened the idea of improvement into what came to be known as the triple aim. The triple aim refers to the social need for better health care. I just told you one of those social needs. That's for better care when you're ill or when you're in the healthcare system: safe, effective, patient-centered, timely, efficient, equitable care. But there's a second aim. Why did you need care in the first place? Why did you have your heart attack? Why did you get a broken arm? Why are you depressed? Well, it turns out that a lot of the generators of ill health that require care lie outside the healthcare system, but they're also crucial in order to achieve the second goal, which is improvement of the health of the population. So goal 1 is improvement of care. Goal two is improvement of population health. And the third is to do that under resource constraints. That is, to achieve better care and better health and lower cost, but not lower cost by withholding care from anyone that needs it, not lower cost by cutting back on care. It's lower cost through improvement. We know in other sectors of our lives that when something is defective, it tends to cost more than when it runs well. Well, the same is largely true in healthcare. When a patient gets a needless infection or a pressure ulcer or there's a medication error, or when we fail to coordinate care for an individual, costs go up, not down. And when we improve the care, costs go down, not up. That's the three-part aim: better care, better health, and lower cost through improvement. That's the what. That's the what we should be pursuing together, I think, globally, in terms of better meeting the needs of populations. What about the how? How do we improve? Well, a bankrupt, outmoded, unscientific approach is just to say, demand it. Tell people to try harder. Tell people to work harder. Well, that doesn't stand up to the test of science. When one looks at processes that don't work well in healthcare, the problems lie in the design of the healthcare system, the way the system was built, the way it's delivered. Take a patient, we'll call her Mrs. Jones. Let's say she has congestive heart failure and she's elderly and frail and has a little bit of depression and maybe high blood pressure. Now, Mrs. Jones can stay well for a long time if and only if the healthcare system around her weaves a net of support, helps her navigate through her illness. Maybe she goes into the hospital with congestive heart failure and is treated well there and then goes home. Now, what will happen to her at home? Will she get worse with nobody noticing? Will her depression cause her to stop taking her medications? Will she gain weight due to fluid buildup and eventually have more and more trouble breathing and end up back in the hospital? Or will we build a team around Mrs. Jones? Will her care be seamless, coordinated, handoffs going really well, people anticipating the kinds of problems she might get into, educating her and her family to avoid the complications that might occur? Will we be working on the upstream causes of her depression and of her congestive heart failure? Will she understand diet and nutrition? Will she get exactly the right medicines that she needs and none that she does not? This requires teamwork, coordination, and an attitude of improvement in the healthcare system around her. Indeed, it needs a system. Healthcare wasn't built that way, not in the United States anyway. It was built in fragments: hospitals, doctors' offices, laboratories, ambulance companies, and so on. And so that Mrs. Jones doesn't stand a very good chance of having that seamless, coordinated care, and therefore her care won't reflect the triple aim. It won't be better care, better health, and lower cost. It'll be care with defects, not working upstream on the causes of her illness, and higher cost because of complications. Redesign of care, all together, everyone involved, contributing what they can in a scientific way to the design and redesign of healthcare. That is the answer. Around the world, we have many, many best practices, organizations and systems that have solved the problem of taking care of Mrs. Jones. They have coordinated teams. They know how to have reliable care. They may have electronic medical records to support that care. They work hard on science-based care using evidence-based guidelines as the guide for caring for the patients. And most important, everyone's in it together. They're all working well together. We can use these best practices, learn about them, and then help spread them among us with an attitude that is focused on improvement. Everyone can help. This isn't just an American or U.S.-based problem. Every country I've had the privilege of visiting is facing the same issues in providing care that has all those characteristics of excellence, in working upstream on the population's health, and also reducing costs through improvement. I'm delighted that you're together in Latin America more and more, trying to work together on the improvement of care. I hope you will be able to join a very important gathering to collect even more knowledge together and create even more energy for improvement throughout Latin America at the first Latin American gathering on quality and safety in Cartagena de Indias on June 20th through 22nd at the Hilton Convention Center. You'll be very welcome there. That will coincide with the 21st CGH International Forum, which is in pursuit of better care, better health, and fairest costs. Altogether, we can arrive at innovations in healthcare in any country and throughout the world that will really achieve for patients what they want: better care, better health, and lower cost through improvement. Thank you very much.